please.
I'd like to speak to you about how do you choose an implant. The implant should be patient-specific. It is unthinkable that in 2014 you tell a patient, you know, I'll put a 300 implant in you, or I'll put a 400 implant in you, or I'll put 250 implant. It doesn't mean anything. It's senseless. Because rather than talking about the volume or weight of the implant, you should speak about the dimensions of the implant. Because the dimensions of the patients are different. Mostly the base width of her implant, of her breast, of her chest wall, and so on. Yes, you should consider the patient's wishes, because if a patient tells you a priori that she wants to have a larger breast after cancer, then you should think maybe I should put a tissue expander because I don't want to stress the skin envelope too much. You also need to consider adjuvant therapies, chemotherapy, radiation therapy, that she might need after the mastectomy. Why? Not because that it is contraindicated to do a reconstruction before those, but only because that complications of your reconstruction may delay adjuvant chemotherapy and radiation therapy, and you don't want that. You want the patients to be able to go along the schedule as the oncologist and the radiation therapist want it. If you cause too many patients to be delayed for their adjuvant therapies because of complication of your reconstruction, it's not a good idea. And the process of selecting an implant for a patient for immediate or delayed reconstruction is very much like the process of choosing an implant for breast augmentation. So, choosing an implant for breast augmentation is easy? No. Why not? Because we have been doing breast augmentation for 40 years, and our best attempts were not very successful in getting a good result. Why? Because the breast is a very unstable organ. It's subjected to hormones, pregnancy, congestion, lactation, menopause, gravity, fluctuation of body weight. The implant hopefully doesn't change much over time, but everything around it does. So you have two partners that are trying to live together. One is totally unreliable and unstable partner. It's the breast. It's getting old all the time. The other partner, we hope that the implant is very stable, but depends what implant you use. So to get a lifelong improvement of a breast by simply putting an implant in it is oversimplifying. It's much more complicated than that. Breast elasticity is specific to different patients. Some breasts are very elastic, very soft, some are hard, they're different. But whatever they are, they reduce with time. It doesn't get better. It gets worse all the time. The amount of stretch is directly proportional to the weight of the breast and inversely proportional to the elasticity. This is Hooke's law. Hooke's law says that a spring has its resistance to stretching. And the more you stretch, the more it pulls back, wanting to be back to its normal size. It is affected by the mass. And if you look at these two women and you ask yourself, which breast is going to age more rapidly, of course, it's the one on the right. Implants of any kind are very powerful manipulators of soft tissue. You know, you can put a tissue expander here and expand the scalp as much as you want. A simple implant may act as a tissue expander even if you don't want them to do so. The larger the implant, the more unpredictable the stretching, and if you have to begin with thinness and laxity, then it contributes to poor results over a long time. These were principles that apply to breast augmentation. Do the same apply to breast reconstruction? Well, you don't have a breast. You only have skin and some subcutaneous tissue, which are not very well vascularized. You could either do a total muscle coverage with a tissue expander and have no tension on the skin to begin with, but eventually there will be tension on the skin when you expand everything out. Or you could do a partial muscle coverage with an acellular dermal matrix, which does not stretch. The long-term behavior of these matrices is not very clear at this time. So when you look at these options of an acellular dermal matrix or any matrix on your right and the patient's own tissue deepithelialized skin, they are not the same. You have to decide whether you use a tissue expander or an implant. What does it depend on? It depends A, on what type of mastectomy was performed. B, on after the mastectomy is performed, how is the tissue that you are given to make a reconstruction? Is it enough in quantity to cover the shape and the dimensions and the size of the implant that you want for that patient? And is it enough in quality of blood perfusion to do the job? What does the patient want? And are there any plans for postoperative adjuvant therapy? When you have a lot of tissue, breast, the breast determines the shape of itself, not the implant. But when you have very little tissue, only skin envelope, then the implant determines the shape of the breast. So it is clear that you need to have shaped implants, anatomical implants, and not round implants. The implant height that you choose for those patients is usually a full height because the dissection of the mastectomy goes higher up above the boundaries of the breast. Projection depends on the skin elasticity and quality for every patient. So this is a patient that had an augmentation. He would publish in a chapter that I wrote with Constantin Stan from Romania. She had no breast, or very little breast, and she had a round implant, and 10 years later we exchanged the round implant to an anatomical implant. There are definitely clear differences between the middle and the right. And here they are. The implants are different in shape and in size, and so is the breast because she has very little tissue. The same is to be expected in breast reconstruction. Here are two patients, two implants with different projections. Same size, different projection. And you can see how it looks different, and certainly it will look like that when you choose an implant for breast reconstruction. In breast augmentation, look at this patient from the side. She has a bulge here, and that bulge is pronounced by the depression above that, which you definitely will have in breast reconstruction. So if you want to fill that, do it on the other side and erase it. This, in a patient with a small breast, which is thin, is the difference between a round implant on your right and a shaped implant on your left. So, every time when you have very little tissues, there is no question that you should have a shaped implant to get a natural breast that doesn't look like a ball. Especially in reconstructed breasts, where the blood supply that is coming from the intercostal, from the pectoralis major muscle is completely gone, and you're left only with the blood supply that's coming from the skin, and then you have a domain that is made of muscle, acellular dermal matrix, and an implant. Everything above that is skin only. So you better choose the right implant for the patient to look right. In breast augmentation, we make all these measurements. Usually the position of the nipple from the suprasternal notch, the position of the nipple with the arms up and with the arms down, the base width of the breast, and the elasticity of the skin of the patient. This is taken from one of my patients during an augmentation, talks about a tissue pinch and a 3+ elasticity. Same patient during surgery, sitting up before we close the wound with an M medium height full projection implant, 295, with a smooth upper pole of the patient. This is how I put the implants in, washing them in antibiotic, after washing the pocket in antibiotic, turning the implant 45 degrees to the side, and then rotating the implant into the breast until the points of reference on the implant are in the center axis of the breast. I do the same thing during breast reconstruction, and everything is done under direct vision except for one motion. This is a motion. This is the only motion that I do without looking inside the pocket. Then again, I look that the implant is centered, also in its anterior surface, posterior surface, and then look at the patient sitting up with one breast has the implant, the other breast doesn't. You can see the position of the nipple, which is lower on the side where the implant has not been inserted yet, and this is the patient sitting up as I've showed you before. So let's look at this patient for a minute because we took her video. This is her 5 years down the road. Same patient before and 5 years down the road. Stable breast. Stable breast. This is what we want. We want the breast implant to slow down the aging of the breast, not to accelerate that. And certainly the same applies for breast reconstruction. This patient also had an augmentation by me, and a moderate augmentation, medium height, shaped implant, full projection, 255. This is 8 years post-operatively. But I want you to look at this picture. This picture is 12 years post-operatively. Look at the two pictures on the upper right with her arms up. Everything in this patient around those implants changed. She has gained 10 kilos. She still looks great, but her breast has stayed very stable. This is what we're looking for. So, the factors that you should consider when you're choosing an implant or an expander is the quality and the quantity of the skin envelope, the shape or the round implant, and obviously you're going to go for a shaped anatomical implant. You obviously are going to go into a macro texturing because you want tissue adherence to prevent the implant from rotating. And then you need to know the dimensions and the size of the implant. How do you decide that? Well, we used to do MRIs. It's very expensive, it's not available, and it's inaccurate. We used to do ultrasound, it's even worse. So we have now gone into two modalities. One is plastic balls, which is very simple, very cheap, and feasible to do, and good estimation of the breast volume every patient, and of the three-dimensional photography, which also a lux that not everybody can afford, but it's very, very helpful. These are the plastic mod. There are 14 of them. Okay, they're made in Sweden. They cost, I think, 200 euros. and they have all the sizes that you possibly can need to assess breast weight. So here's a patient like that, one cancer in the left breast. We have assessed the volume of the breast to be 275 with the salad balls. We assessed it to be 290 with the 3D photography, and in reality it was 283 when we took it off. So we put a full height, medium projection implant on her and got a pretty good symmetry of size and shape in this patient. Then you need to decide which implant you put. You could put the shape adjustable implant, which is a double lumen implant, which is a very good idea to use in many patients because you can put it 50% empty and then fill it up as everything is healed. And I think in people who are starting to do breast reconstructions and immediate breast reconstruction, this is a very good implant. The other is a tissue expander. If you decide that you're going to go into a two-stage on these patients, this is always a good way to start. And finally are the 410. I speak about Allergan because this has been my experience. Obviously there are other companies that have good implants. I have no experience with them. This is a company I have an experience with. I like their design and they have worked for me. When I choose a shaped implant for these patients, I usually use an implant that has a cohesive gel. Cohesive gel because I want the implant to keep its shape because I have a very thin skin envelope over my reconstruction. And I want it to look good. I don't want to see wrinkles over time. You get muscle atrophy over time. I want the implant to shape the breast long term. So let's look at some of my patients and I will finish with that. This is a skin-reducing bilateral mastectomy. 5 years follow-up on this patient with an FX, full height extra projection. All the extra projecting implants have a highly cohesive gel to maintain their extra projection. So here she is. Another patient with a 10-year follow-up with a skin-sparing mastectomy, bilateral, with a lateral incision. She's had radiation on the left side, and she maintained her symmetry. We'll talk more about that tomorrow. Another patient with a nipple-sparing mastectomy, incision in the IMF, with an augmentation type effect because her weight of her breast were 120 and 133, and the implant of medium height extra projection were 325. And here she is 4 years after mastectomy, and in oblique views, that's her as well. Or another patient had a skin-sparing mastectomy on the left, a breast augmentation on the right, and this is 6 years after radiation. So we must be doing something wrong, but something right. But when I say that, it's the general surgeon, is the plastic surgeon, is the radiation oncologist, because we all work together as a team. So, choosing an implant for breast reconstruction is patient-specific and based on her tissue, just like on breast augmentation. Consider her wishes. Consider the implant or expander choice according to what awaits her post-operatively, and should be like the process of breast augmentation. Thank you very much.
Спасибо большое за прекрасную лекцию. Вопросы?